Good morning, everybody. I see that we already have an amazing showing for this illustrious group of presenters. And I think we have definitely enough people to start so that we have as maximum amount of time to discuss this very interesting topic. So before the intro start, I just want to thank Carlos and Miriam on behalf of the Surgical Education Group for putting these amazing rounds together. And of course, thank you to all the speakers. And the floor is yours.
So, well, after that generous introduction, good morning, everybody. My name is Carlos Gomez. I'm an assistant professor at the Institute of Health Sciences Education and also an associate member of the Department of Surgery at McGill University. And today, I'm really honored of introducing this panel conversation about artificial intelligence and its uses in surgical education. So this is the first of many activities that we at the Surgical Education Group have prepared for the department. And we really wanted to start this series of events with really a timely conversation about a topic that we might have heard constantly in our practice, but we will really want to hear from experts about what are the characteristics of artificial intelligence and how we can use it to advance our understanding of surgical competence and how to acquire surgical judgments and obviously their competence as well. So today we have four fantastic panelists, and I would like to thank all of you for being so generous with your time. So it's an international panel of experts on artificial intelligence and uses in surgical education. And how this activity is going to proceed is that each of the presenters will have 7 minutes for a presentation. After those 7 minutes, there will be the introduction to the next panelist. And at the end, we will have an open forum for all the questions that you may have that you can actually ask to our experts. And we will have also as well a discussion with our panelists about some topics, burning topics on the uses of artificial intelligence in surgical education. So if you have any questions, so one of the benefits of having these rounds via Zoom is the fact that you can actually type your questions on the chat function. We will keep an eye on all the questions or comments that you may have. And when it comes the time for the conversation with the panelists, so we will deliver and we will read those comments to the panelists so you can hear from them about their thoughts on whatever the issue you have raised. So without further ado, I would like to introduce our first panelist, who is someone who is really familiar with the department, someone who received her PhD at McGill University in the Department of Surgery, the program of experimental surgery. Her name is Elif Bigic. She's an assistant professor in pediatrics in the Faculty of Health Sciences and in McMaster University. Her program of research is in the field of performance assessment across medical specialties, exploring how to optimize assessment in the clinical and simulation setting, focusing on technology, innovation, and collaboration, ensuring that trainees are gaining the necessary skills to provide the best patient care possible. She has 2 recent articles published related to our panel discussion today. The first one is Scoping Review, exploring the roles of artificial intelligence in surgical education, that you can find in the American Journal of Surgery, and also the article entitled Artificial Intelligence in Surgical Education, Consideration for Interdisciplinary Collaborations in Surgical Innovation. So with that, I will pass the torch to Dr. Bigic, and you have your 7 minutes starting now. Thank you.
Great, thank you so much, Carlos. Quickly share my screen. Okay. Can everyone see my screen? Okay, perfect. Well, thank you very much for the introduction. I'm very happy to be here, to be back in the Department of Surgery rounds. And as Carlos mentioned, I'm the first speaker, so I will be really, hopefully in the next couple of minutes, introduce AI when it comes to surgical education, and try to give you a a brief definition of AI that we could use and think about when it comes to, again, AI in surgical education, and look into some of the characteristics and classifications of AI. And just in terms of disclosures, the main one is, I think is one that Carlos mentioned, is that those work came from the work that I've done with Dr. Harley with a short connection grant. So I will be definitely talking about those. Now, I have seen this article before in the McGill Tribune, right? The title is AI Will Train the Next Generation of Expert Surgeons. And when we look at this title and when we see this picture, I think we all think about, what does this really mean? Does this mean that we're going to replace surgical educators when we're training residents throughout their surgical residencies? And what does that so what does that mean? And I think in the article there's a statement that quite nicely explains what I think AI in surgical education is really all about. And it says, Dr. Del Maestro anticipates a rise in human-machine cooperation, where AI analyzes student performance and instructors use that information to better guide students. And just in case of those of you who don't know, Dr. Del Maestro is an expert in AI and surgical education. I've been doing a lot of work with, especially virtual reality simulations in neurosurgery. And I think this idea of human-machine cooperation is really the key. It's never about replacing anyone, but more, can we augment the surgical training through this cooperation between surgical educators and AI systems. And as I was, when I was looking at the literature when it comes to AI and surgical education, I found that literature that defines and describes AI is quite fragmented, probably mostly because there are diverse views and reactions to AI-enabled technology. And so something that we've done is we just looked at various AI adjacent fields to really understand how we could define AI in surgical education. So a definition that we came out with is here, which is published in the article that you can see at the below. But in surgical education, one of the definitions of AI could be that AI is an intelligent agent system or program that acts to fulfill or support the fulfillment of educational tasks traditionally performed exclusively by surgical educators through making decisions in a manner similar to educators and providing customized adaptation, including performance assessment and feedback to surgical trainees. Now, I want you to keep this definition in mind for the next couple of slides that I'm going to have. Now, technology enhanced teaching and learning is evolving quite rapidly. I mean, for some time now, including development of these AI-enhanced applications. And these advances focus on creating adaptive, flexible, student-centered, personalized, and digitized educational environments with automated assessment and feedback as ways to improve skill. And in the pictures that you see on the right side, this is actually from an article where they've used a virtual reality platform but augmented it through AI for performance assessment. And basically, once a trainee performs a specific task, they get feedback through this system. They determine if they're a novice or expert and where they need to improve upon. And then they have to repeat the task until they achieve a certain score. And again, the idea of student-centeredness and being able to repeat tasks and improve their skill is very important. And again, these performance assessments are done automatically, so it's always a bonus when that's done with quality. And with COVID-19, with the pandemic, I think there has been even more interest in these kinds of technologies, just because one, certain things can be done remotely, certain education, but also for these kinds of platforms where there's automated feedback and assessment, you don't need the physical presence of an educator, which could sometimes be difficult to have. And so, and with all of that in mind, I think there's, one way to, I guess we could classify AI when it comes to surgical education is looking at it from a rule-based versus non-rule-based AI perspective. Though there are, of course, other ways of classification, but I think this makes most sense for surgical education. Rule-based AI is really more about these predefined outputs that are based on rules that are programmed by people, and it's exhibiting fixed intelligence, which basically means that the AI system is following a set of rules and instructions to get to certain predefined outputs. And intelligent tutoring systems tend to be a good example of that, where, let's say, a trainee is performing a specific module online, and they're asked to complete, let's say, a knowledge test along the way, and based on the scores they get, the AI system, the intelligent tutoring system, sort of adjust the module so that those specific components where the student has weakness can be addressed. Again, that flexibility and adaptability is quite important. And then we have non-rule-based AI, which is the most common that you see in surgical education, is where really you're using AI, without necessarily relying on predetermined rules. We're building algorithms that automatically adapt to change. And for example, a machine learning algorithm that's able to classify patterns of performance that distinguish between various expertise levels is a good example of that. And just final thoughts, in terms of important considerations, I think we have to realize that to build AI and as educational technologies that to help teach and help people learn, and we need to understand that expertise is specific to a domain, and that a key component of expertise is deliberate practice with repetitive goal-oriented practice, and with, of course, well-informed mentors. And with AI, mentors can be both the AI softwares, but a cooperation, again, between the humans and AI. So it doesn't have to be just the surgical educator who's a mentor. But also with AI-enhanced educational technologies, we're inferring about a student's performance through assessing their knowledge and skill. And then we're really using that to make adjustments to the activities that student is doing, so that we can target and develop those specific knowledge and skills, which is actually true for both classifications that I mentioned. So thank you very much, and I'm looking forward to the discussion at the end.
Thank you very much for the robust introduction. Let's move on to Dr. Daniel Hashimoto, Assistant Professor of Surgery at the Hospital of the University of Pennsylvania. He's a minimally invasive surgeon with multiple areas of clinical expertise, including foregut and hernia repair. He's director of the Penn Computer Assisted Surgery and Outcomes Laboratory and has helped multiple computer vision algorithms for the analysis of surgical video. He's also led international consensus on defining ground truth for the annotation of surgical video. He's worked to define metrics to assess performance of AI algorithms on surgical tasks. His work has been published in numerous journals, including the New England Journal of Medicine, Nature Biotechnology, the Annals of Surgery. He's director of the textbook Artificial Intelligence in Surgery, Understanding the Role of AI in Surgical Practice. And those are just a tiny few grains of his bio. So thank you, Dr. Hashimoto. It's over to you.
Thank you very much, Dr. Wagner, and thank you very much for the privilege of joining you today. When I was a student, I just read like paper after paper after paper about surgical education coming from McGill. And for me, it's an incredible honor to get to speak to all of you. So thank you very much. A couple of brief disclosures, but I'm not talking about any of the work that I've ever done with any industry or anything like that. Although I'm part of a nonprofit with one of your graduates, Dr. Amin Madani, that focuses on sort of increasing access to AI for surgeons and for engineers. And what I really want to talk to you about today in my time slot here is really about some considerations in doing surgical education research involving artificial intelligence. And a lot of this is actually going to sound pretty familiar because it's a lot of the basics in terms of how we think about research questions in general and how we think about designing studies. And so the framework is going to be very generic in the sense that you want to define a problem. You got to understand the data that you want to use to explore that problem or to probe that problem. And you really want to think critically about how you select the method and interpret the results. But I think within that framework, there are a couple of nuances that I always try to share when I think about some of these problems in terms of applying AI for the types of problems that we deal with. I will say that I'm a bit biased. I give my perspective from the framework of doing computer vision research, particularly in surgical education, because that's my main area of focus and interest. So forgive me if all of my examples are computer vision based, but I do think in general, they would be more broadly applicable to different types of surgical education research studies. And I think that when I first approach problems or when I work with my team about this, the first question we often ask ourselves is this an engineering problem? Like, is this an AI problem that we're trying to solve, or are we trying to solve a surgical education problem? Is it that we're trying to apply known approaches that we know work in the field of AI to problems in surgical education? Or is it that we want to start from scratch and really start from the foundations of machine learning and really think about new architectures for training algorithms or exploring algorithmic learning? And I think that's really the first thing, because it's really going to drive what you're hoping to achieve in terms of results. And sort of we'll build on that thought as we move through here. And then the second question is if you are doing a more surgical education focused problem, is that problem amenable to using machine learning? And do you even need machine learning? Can you solve it by using different approaches? One example that I'll give from computer vision is oftentimes when we're looking at operative video, our first sort of immediate fallback is to say, we're going to use deep learning to do X, Y, Z, when in reality, we might be able to use even older techniques like optical flow to do some of the analysis that we want, like where is something moving across a screen. And so we don't need to use all this extra compute and all the extra data that we might otherwise need if we're trying to use something like deep learning. And so when I define the problem, I really think about it from that perspective. So I think it's preaching to the choir, at least at McGill, to talk about sort of what's the value of using something like video to do things like case preparation, coaching, and feedback, versus also thinking about video from the perspective of, oh, if I can use AI, I can actually detect specific events and try to correlate them to outcomes. Well, I think each of these has a very different approach at how I want to set up that problem from an AI perspective. On the one hand, if I'm thinking about it from the perspective of sort of just using it for case preparation and coaching from a human perspective to facilitate human learning, I may not need as much computationally expensive approaches to do that. And I want to think about, well, what type of performance am I looking for from my algorithms so that I can quickly index cases for review and feedback, versus if I want to be able to say, this particular moment in time is when the bleeding started, and that's what led to their poor outcome later on. That's a different setup and may require more data and more computationally expensive resources. Similarly, when I think about setting up problems, you want to think about it from the perspective of what do you want to achieve from surgical education? Do you want to, as Dr. Bigic had presented earlier, try to achieve sort of feedback in a simulated setting? Do you want to try to do that in a live operation? Are you trying to help people just sort of confirm what they're seeing? So, for example, the group in Strasbourg at IHU has done a lot of work around helping people sort of confirm what they're seeing in terms of identifying, for example, the critical view of safety in gallbladder surgery, or to identify that relevant clip. But does that necessarily help somebody achieve the critical view of safety, or does it just tell them when they got it and when they didn't? And if you want to help somebody achieve the critical view of safety, is it enough just to say, no, you didn't get the two structures, or can you provide some additional guidance on top of that? And so as you work through that, you want to think, oh, do I have the data available to tackle that question? And more importantly, is it applicable to that question? And perhaps more specifically to the AI component, is it annotatable? Is the concept that you want to try to use AI to try to distill, can you annotate that? Can a human look at that video and say, yes, I can actually mark for you here, here, and here, the types of signals I may be looking for, or the relevant type of input that I may want to ultimately yield the output to answer my question? And then one thing I always point out is my fourth A when I think about data is, does annotating your data depend on an attending? Because if it does, it's never going to get annotated. And so it's really better if you're able to think about questions where you're able to really try to scale resources in terms of having either residents or medical students or even lay people annotate some of the data. And to think about clever ways to bring annotation into workflow that doesn't make people think like they're doing an extra step, I want to highlight the work of Dr. Amin Madani, who's one of your graduates. And when he was in his PhD, he had come up with a platform to try to better understand decision-making and operation, such that a trainee could be shown a video of a lap chole, for example, and then be asked to annotate where they would want to start their dissection. Well, he was able to compare that to experts and then subsequently took all of those annotations that were being used to teach to also train a machine learning algorithm such that he can now do sort of real-time demonstrations of where it's safe to dissect or not safe to dissect to help people get to the point of getting to the critical view of safety. And I think it's important for us to really remember that, of course, all data is biased. It's not just the bias of, how you're labeling things or are your classes balanced between groups, but also think about the types of patients that you're or trainees that you have in your studies and whether they're reflective of the general population. And when you think about setting up your methods, also think about whether you're shooting for the state-of-the-art in AI, keeping in mind that some things like in computer vision, getting a 2% higher rate of accuracy is considered a big deal, where it may not be as big of a deal, for example, in surgical education to say, oh, can I get 2% faster than I was last time? And then I think most importantly, it's really thinking about, can you measure the performance of the algorithm? So as just a very quick example of that before I wrap up, we all know that surgical decision-making is not linear. The mental model for how we do surgery doesn't go from left to right, steps 1, 2, 3. It can be a big web of decisions like you see in this picture. And when we think about how to model that from an AI perspective, we also want to try to break out and understand what are the multimodal ways in which we can think about these problems. And that's how you want to start setting up your models. So when you're working with engineers to set up this research problem, you really want to get in depth into trying to have the team understand what is it that you're actually trying to approximate and model, and are there appropriate architectures that you can utilize to more closely match with what you're trying to achieve from a surgical education and AI perspective. And then I think probably most importantly, I don't have time to really get into deep details, but I put the QR code. It's really thinking about your appropriate validation metrics. And so really thinking about how you want to appropriately assess whether your algorithm is working or not, because a lot of the metrics that are being published today are actually not the most ideal metrics to assess certain things. Even, for example, are you appropriately highlighting where the gallbladder is and things like that. Ultimately, some of these things can be used in terms of interpretation. I want to give one quick example and close, which is that, for example, if you use AI to try to predict the likelihood of creating a hole in the gallbladder and spilling bile, you might find that one surgeon is most affected. And you might take this data and say, I probably shouldn't have this surgeon doing gallbladders anymore because, look, they're 3 times more likely to cause a leak of bile from the gallbladder itself. But when we dug into this data, what we actually found is that was the attending that was probably the most experienced and letting the residents do the most. And so if we had banned that surgeon from doing cholecystectomies, not only would we be losing an experienced surgeon, but I think trainees would be losing an opportunity. Now, we were able to use this feedback to sort of demonstrate sort of what was happening when more complex gallbladders, and they were able to tailor the instruction, the amount of autonomy they were providing to some of their residents. And so I think that's one of the things to think about when we think about how we interpret some of the results of these AI studies. There are, of course, a lot of behavioral obstacles that we can get into in the panel in terms of how we can incorporate some of this research. But I think suffice it to say, we really have to think about overcoming limitations in data, limitations in compute, and limitations in some of the regulatory structures that we have in doing these studies. And so the takeaway points, I think, is whenever we do a surgical education study, think about whether you even need the AI. And if you do think you need it, do you have the right data available to do that study? And then however long you think it's going to take, you should probably double it because it's going to take longer time to get the annotation to compute right. And then just remember that while storage is cheap for some of this data, the compute can be expensive. And so you want to think about the right type of machine learning algorithm and architecture that you may want to use. Thank you very much.
Thank you, Dr. Hashimoto. That is so much to think about. Such a rich presentation in a short time. Our next presenter is Dr. James Jung, and a special shout out and a thank you to him as he's on vacation and taking time to be here. He's an assistant professor at the Department of Surgery, University of Toronto, and has trained both at the University of Toronto and Harvard Medical School. He's a minimally invasive surgeon at St. Michael's Hospital, focusing on foregut, bariatric, and abdominal wall hernia. He's also a scientist at Li Ka-shing, Knowledge Institute of St. Michael's Hospital. He's an MD PhD, having earned his PhD in clinical epidemiology and health services research through the Surgeon Scientist Training Program at U of T. His primary research interests are in using machine learning for the early detection of clinical deterioration in surgical patients. And Dr. Jung has published over 30 peer-reviewed papers and several book chapters. So welcome, and the floor is over to you.
Well, thank you, Dr. Wagner, and thank you, everyone, for this opportunity to present some of our work today. It's a real honor to join you here for the McGill University's Department of Surgery Grand Round. So I think my talk is going to be a little bit different than my colleagues in that it doesn't primarily focus on surgical education, but I think there are some takeaways that are, that may be valuable to this audience. So I don't have any personal disclosure to make that's relevant to this talk, but this is truly a collaborative project where we collaborate with several scientists and engineers across our hospital, as well as Department of Surgery at the University of Toronto and several AI institutes. So the clinical problem that I want to talk about today is the delay in recognition of clinical deterioration. So despite our best efforts of the frontline clinicians, there's inevitably a delay in recognizing when patients are deteriorating. That means being transferred to the ICU unplanned or dying in hospital. It is a leading cause of unplanned ICU transfer. There is a delay even when the patients meet the ICU transfer criteria to get to the ICU. And I think this audience recognizes well that the delay in recognition leads to a failure to rescue and even death. So I think this quote kind of summarizes it. It may be a little unfair, but patients don't suddenly deteriorate, but healthcare professionals suddenly notice. And some people will say, the data is all there. Since the advent of electronic medical records, how could he have missed this? But when we look at it under the hood, the EMR is really clunky and inefficient. Just think about how many clicks you need to make in order to get to the right information. And since the advent of EMR, the length of patient notes have doubled or tripled because there's a lot of carryover and copy and paste of data points. And there are really a lot of data points that when you're covering patients over the night or the weekends, there's a lot of data to sieve through to get to the right point. So when we thought about building an AI solution to address this clinical problem, we set out a few criteria. First is the AI clinical tool, prediction tool, has to be highly predictive, has to perform better than human clinicians, and the prediction should be made real time. It has to be easy to communicate and understand, and there should not be any additional input from clinicians. Just think about the risk calculators where you have to put in the patient demographics or comorbidities. That just is not feasible model in our busy clinical workflow. And it has to be associated with the standardized and sustainable care process. So first, in order to build that kind of platform, we first have to have a strong data governance. This is a real quick overview of our data governance here at St. Michael's Hospital. First we start with the data access, and this has to be an institutional-wide, private, and robust data access. And we access all the relevant clinical data. We use a legacy EMR, so the data is a little fragmented. So we have to understand where the data has to be sourced from. So in the ED and admission, discharge, transfer data that understands the demographics, and all the data, the in-hospital EMR data, including all these data features. And then we could extract and transfer these data to our secure server where we could start performing the data engineering. So it starts with data cleaning, processing, and developing models such as machine learning models. And then finally to the product development, which often is a software for us. And this is overseen by our project management team, which kind of whips us all into action. And then that is overseen by the privacy, legal, and oversight committee. So we built this ChartWatch program, which is an AI-enabled platform that surveys the EMR data points and make real-time predictions. And we set it to an hourly predictions. It runs 24/7. It's highly predictive. It relies less on subjective assessments. In the quick overview, the patient data is inputted into model. And after the after the predictions scores are calculated, if it reaches a certain threshold, then alarm is triggered and the notifications are sent to the caring team, and the care pathway is initiated. And I'll get to that a little later as well. So this is one of the ways that we communicate our findings. This is the e-sign-out tool that we use at St. Michael's Hospital to track where the patients are in your team. And then we provide a real-time update in the chart watch column. And oftentimes we don't use this every hour. So if there's a patient that goes into the high alert for the first time, then a pager notification is sent to the caring team as well. And as a hospital, as an institution, we agreed upon the following. When the alarm is triggered, then the physician from the responsible team should reassess the patient within 2 hours of the alarm and assess the patient for potential causes of clinical deteriorations. So this was instituted in surgical wards starting in November of last year. So we don't have a lot of data, but this program started in the GIM. So I could share a little bit of our clinical outcomes from the GIM experience. And this is an unpublished data. So we've implemented the ChartWatch in the 6 GIM teams over the 2 years time in this study. This accumulated over 6,000 patients. And we compared before and after implementation and compared to the historic cohort after propensity score matching. And these are the results. First of all, the AI predictions for clinical deterioration is superior than clinicians' prediction for clinical deterioration. And I think most importantly, there's 15% relative reduction in mortality compared to the historic cohort. And subsequently, there's an excellent take-up by clinicians. And this has led to expansion to surgery and will lead to a hospital-wide implementation. So I have sort of 3 takeaways that I found during my time working on these models. First is that the machine learning model, one model does not fit all patient populations. And I think this audience will know this, that surgical patients are just different. I told you that we started from GIM patients, and a lot of the data engineers thought you could just apply this model that you learn from GIM, just transplant that into surgical patient wards. It just doesn't work that way. Our patient demographics are different. The distribution of data points when they're collected are different. We focus more on perioperative time period, and input variables or features are different. We care more about OR notes, where GIM patients, there's no such thing as procedure notes usually. So when we started our work to bring this to surgical wards, we actually started from the beginning. But you could also do transfer learning with some modifications, but clinical insight is very valuable. And of course, validation process is very important. Second, there really has to be an institutional support, institutional buy-in. As I mentioned before, the data governance has to come first, and then you could perform data engineering. And really, you can't really establish data governance, on your own. There has to be an institutional support, institutional access, and there is a high startup cost. So there has to be an institutional buy-in from the beginning, and we have to make a steering committee that involves all the stakeholders. Lastly, I think this is the most important point: is that the artificial intelligence, machine learning is just a tool. This really is a clinical research, clinical science, and we're applying the features of the AI that we find particularly valuable in increasing the prediction. But really, from the beginning, this has been a clinical research. So thank you again very much for this opportunity. I look forward to our discussion.
Thank you, Dr. Jung, and you've certainly situated AI in a very, very practical context. So thank you very much. It's my pleasure now to introduce our last speaker, who notably is also in the Pacific time zone, so it's extremely early in the morning. So thank you. And that is Dr. Ruchi Thanawala. She's an assistant professor of surgery, Division of Cardiothoracic Surgery, School of Medicine at Oregon Health and Science University. She's a true Renaissance woman because she's surgeon, entrepreneur, and inventor. She's a cardiothoracic surgeon focusing in thoracic surgery. She's a trained clinical informatist. I can't say that word properly. Focusing on data science. As an entrepreneur, she initiated a startup during her general surgery residency. She's a co-inventor on a U.S. patent on comprehensive surgical education platform and novel learning curve algorithms. And she has numerous publications, including Overcoming Systems Factors and Case Logging with Artificial Intelligence Tools, published in the Journal of Surgical Education. So welcome.
Thank you. Hopefully you can see my slides okay. Thank you very much for the opportunity to be part of this wonderful panel and present at your grand rounds. A lot of my research sits in the space of creating larger models on how we understand how we learn. So today, I'd like to talk to you about some of my work in modeling entrustability. For my disclosures, I co-founded the company Firefly Lab. I'm a stakeholder in it. And some of the data that I'm discussing in the study was derived using that platform to complete evaluations. So my work has focused on the use of machine learning and AI tools to model how we learn in the operating room. So I'm interested in the synthesis of discrete large data sets to build generalizable models that are applicable across multiple different data sources, so we can build on our understanding of complex learning, in this case, surgical skill learning. So using machine learning, we've talked a lot about AI and machine learning as tools. One of my primary focuses in my group is the development of quantitative models of entrustability, followed by the application of optimization algorithms to really keep our learners at the apex of their learning. And machine learning it's a tool. It's a tool that helps us, but can we actually extract the information that exists within the brains of surgical educators and put it in front of the trainees, make it transferable across educators to help keep our learners learning at their highest apex? So I'm going to bring in the concept of EPAs, entrustable professional activities, that almost everyone is acquainted with. So these are professional practice units that a trainee should be proficient in before undertaking them independently. So how can we use machine learning to predict the likelihood a trainee can complete an operation to its ultimate objective, taking into account the variable ways an operation can be completed? I want to tie the concept of EPAs into surgical process mapping. So operations are inherently complex. From the outset, we have a general idea the pathway an operation can take. The more complex the operation, the more variable the possibilities an operation can be completed. And then there's an overlay of the probabilities that will drive the likelihood that we're going to end up with one traversion down a pathway. So surgical process mapping allows us to codify this information. And then if we pair surgical process maps with evaluation and feedback data to answer a question, if and can we build a model to predict preoperative entrustability of a resident's operative ability across all procedural possibilities, taking into account probabilities. So I want to take you through the process of how we actually built this model. So through previous work from my group, we've calculated thousands of learning curves that have been derived with computational modeling from evaluations that have come from our integrated platform. We then use further modeling to calculate the resident's autonomy specific to each case, or a component of a case if we have the deconstructed components of the operation. And then predict the teaching faculty's evaluation of the trainee. And finally, we compare the predicted versus observed evaluations, rating for entrustability. So we talked about data, and to train these models takes a large amount of data. We need a large amount to support accurate predictions, to train our models, to validate our models. So for this project, we used nearly 7,500 operative evaluations over four core general surgery operations of about 220 residents. And from this, we constructed 4,000 learning curves using Bayesian and deep learning models. So by combining Bayesian and deep learning models, long short-term memory, neural network modeling, we were able to forecast the entrustability level and predict the evaluation rating for each resident for each procedure type. And this procedure approach took into account operative technique variants. We modeled these using Markov decision processes, another machine learning tool. And our modeling was adaptive to the case type, the surgical team, and the likelihood of conversion. So here's an example. This is a simple model of all the things that can happen in a colectomy. So we know when we're doing an operation, like we start on the left side, there's a colectomy. We anticipate doing a colectomy. It could be a robotic colectomy, laparoscopic colectomy, open colectomy, and there are all these adjunct procedures that really map out the way this case can terminate. And these are the learning curves. So we have the evaluation data. We can use our Bayesian modeling and other computational ML-driven models. And these are the learning curves of a trainee. So if we look at each one of these learning curves, there's a colostomy learning curve, which could be part of, what's necessary to complete a colectomy. There's lysis of adhesions, there's open, and there's laparoscopic. But what you can see, there's a lot of variability in the trainee's skill set. So how do we pull that all together to know from the outset of an operation how likely a trainee is to make it through the entire operation? Because if we think about when we're training our residents, especially in their senior years, is to make it through a case, right, from start to finish. But we don't know until the end how they're going to make it through. And we use our intuition to know when to help them and not. But can we use data and machine learning to help us have a solid model at the start of an operation? Then we can translate these learning curves into these probability distribution maps. So here's a probability distribution map on the right side, which shows, as we translate these learning curves, what is the probability based on the residents' operative autonomy, starts from 0, where the attending had to do everything, all the way to a 1, where the attending didn't have to be in the room. Now, again, this is fragmented by the components. So we're asking our surgeon educators and teaching faculty to integrate all this information, which an individual educator is likely to integrate all this information, but our trainees might not necessarily be able to. And how do we transfer this information across faculty? So here we put this all together further. And now we have an operative autonomy model for an entire operation, taking into account surgical process mapping with the possibilities that the operation can take, the traversions down the tree, in addition with an overlay of the probabilities that each traversion likely has and the residents' likely ability based on their learning curves to get there. So what's not novel is that autonomy varies across residents. We all know that. We recognize that from having worked with trainees, from having been trainees ourselves. But what is novel is we can create a model and codify this and make this available for people to use. And to help really drive the way that we're having our conversations at the beginning of an operation on where a trainee is likely to need help. We went through the process of validating our model as well. And from the outset, we have an accuracy of about 72% and a precision of about 77%. So a fairly good start for this model, and hope to keep, building it forward. So having built this model, the next question is, how do you operationalize this information? And probably one of the most efficient ways to operationalize this information is creating a case assignment decision aid tool that optimizes where trainees are in their learning curve matched to the upcoming operations. So on the right side, you can see, we stratify the learners, and the width of the colors represents the steep part of the learning curve, where they're actually learning at an accelerated rate. And then each color mirrors to an operative case assignment. And at this point, now we're not dependent on, whoever's making the case assignment schedule to just know where the learners are. But we have another variable that's based on machine learning that can help us to know how we can optimize every educational opportunity for the trainees. Another way to think about this is actually delivery fleet route mapping and planning. So, as trainees, as faculty, we're always thinking about ways, scientists, that we can optimize our schedule, get everything done that we can, get everything we can out of a minute. And now, actually, the optimization of learning is a possible thing to include in, our mapping and planning of education. The last model that I want to leave you with is using genetic algorithms to actually start to run learning curve simulations on where our learners are now and where they're likely to end up being. And interjecting in a simulation model, what if we put in certain interventions, like working with certain faculty, because we have learning curves based on, certain faculty and how residents train with them. Skills lab interventions, other interventions, to capture our learners earlier, struggling learners, really fast learning learners, to move them on to the next learning experience. And in conclusion, modeling entrustability, modeling how we understand how our learners are learning. The objective is the liberation of a lot of this information that exists within the brains of teaching faculty? And can we actually put that in front of our learners to help them drive their own entrustability in learning, especially as they're in the transition to practice phase? Machine learning is one of the big tools that I think can help us with this, because what it can do is pull together a lot of information, identify patterns, and put those in front of our users to give them power over their own learning. So thank you.
Thank you, Ruchi, for that very fascinating, I think, review of, probably just touches the tip of the iceberg of the work that you're doing. And thank you to all the presenters for really the amazing different perspectives and such like a futuristic view already. And, Carlos and Marion prepared a few questions to moderate this panel discussion. And I first wanted to just see if there were any questions from the crowd. So is there anybody who has any questions, any comments? Jung, please go ahead.
Fascinating. Thank you. Really learned a lot. One of the things I have a question about is, it seems to me from your talks, it's centered on the learner quite a bit. How do we improve our teaching abilities? I'm kind of returning it to improve not just those who are learning, but there's a lot of us in the faculty who need improvement in how they teach. Because some of us are very short-tempered and not very patient with our residents.
So is there anybody who feels most inspired? Please, whoever would like to address Dr. Trevenkov's question, please feel free, or more than one of you, of course, can tackle it. Ruchi?
I'm happy to start with it. So that's a very relevant question. And you're right, there is the flip side to each one of these. As we're, like, in my work, modeling the entrustability of a trainee, on the other side of it is how are faculty actually driving the learning of each resident. So, we can look at the learning curve for each individual learner, but on the other side, we can look at the educator curve for each one of the faculty. And then are there optimal pairings, which, in a lot of my preliminary work in looking at, there are optimal pairings, and there are optimal pairings at different points in a trainee's learning curve, where the teaching faculty are most beneficial to that trainee to overcome aspects of their learning curve. And, those sorts of models and tools can be used to educate faculty on, perhaps where to improve their role as an educator, where they're optimized as a role of educator. So I think it doesn't take much. It's just looking at it from that different angle to see how we can help faculty, development.
Very cool. And do any of the other panelists want to take a stab at that question, or should we move on to the next one? Dan.
I think maybe not sort of as explicitly answering the question, but I also think about it as sort of some of these algorithms do empower the educator with a little bit more quantitative information on which they can sort of hang their hat on and provide some of that feedback. And at least in some of like the preliminary work that we found, particularly with some of those individuals that Jean, you mentioned, and maybe have a shorter fuse, it grounds the conversation in perhaps somewhat more neutral terms rather than just I think or I feel or the way I do. It's more, look at, here's these numbers, or here's on the screen in a computer vision example, sort of how far off you would be from what's recommended. Let's have a conversation around that. And so it does create sort of different talking points or points around which the teaching can happen. And you're right, though. I think we do have to do a little bit more work about thinking about how this gets rolled out in an effective manner.
Dr. Stein, please.
Yeah, thank you, Melina. I am attending these rounds as a radiologist, but I'm also a member of the Department of Surgery. I'm also on vacation in Siesta Key, and I use that as just a preamble to how did I get down to Siesta Key? Well, AI flew the plane. The pilot was an assistant. And I'll use this, I'll go forward a little and you'll probably know where I'm headed. AI will eventually take out an appendix. It's not Will it? Yes, it will. AI will. And that will be the future. And I want to congratulate all the speakers who spoke today. They're really excellent. But the future is quite amazing, as it is in radiology, with AI reading chest x-rays, CT scans, mammograms. Does anybody have any comments about AI taking out a gallbladder or an appendix or doing a colectomy?
I definitely have comments on that. So actually, most of my training has been in robotics labs, and I'm appointed in robotics here too at Penn. But I can say it sure it will happen, but it's certainly not going to happen in my lifetime, and probably not even in my kid's lifetime. He's 2. I think there's a lot of problems around robotic control that still need to be solved. I mean, that being said, this point about the plane being the primary pilot and the human being the assistant, I think that's a valid one. I do think that you are going to see task-specific automation of tasks. One example might be, at Hopkins, Axel Krieger published about the autonomous suturing robot that can do a small bowel anastomosis. The lay press was all over it that it outperformed a human surgeon. But I talked to Axel, and I asked him how he did that experiment of comparing human bowel anastomosis to robot. The way in which they set up the bowel to do the anastomosis was optimized for the robot. So the surgeon had to actually turn upside down to sew the anastomosis. And so I think that if you were going to do an apples to apples comparison, I think you'd want to probably optimize the anastomosis for the human and for the robot and see what the difference was. And I think that's why I'm I'm not as sort of like high on this sort of autonomous surgery fully yet. Although I think the tasks of it are coming, right? The stapler sort of replaced hand-sewn anastomosis, and I'm sure there are going to be little tasks like that that are going to come into play from an autonomous perspective.
And I think that's why we also need people like you guys to make sure that we're sort of the stewards of this process and that it just doesn't get ahead of us, and I think I've heard many of you remind us about that. And I know that Carlos is also a really strong believer in the stewarding of the use of AI, that it's not just sort of a blanket thing that we can apply to everything. Jerry, please ask your question.
Well, first of all, let me just congratulate Melina on putting together such an amazing panel. It's fantastic, a great.
It's really Carlos and Miriam. Please congratulate.
Carlos and Miriam, congratulations. And I take away what I said about Melina. And I just want to thank all the speakers. And I guess one of the great things about COVID is what we've learned about doing remote education. And that really gets to my question. I have 2 questions, but I'll start with the first one. Maybe I'll address this to Dan. With our experience with COVID and the opportunities for remote education, how can we use this kind of computer vision technology in a practical way in a coaching platform to improve the efficiency of learning? So that's my first question. Then my second one, I'll just ask it if there's time. Maybe you could answer that. Is the level of resolution of computer vision sufficient to ensure that to direct the surgeon into the right tissue planes? Because that really is the challenge. You want to do something like total mesorectal excision. The tissue planes are critical. And do we have that level of resolution?
So on the first one, I think that there's a lot of stuff happening sort of around remote proctoring, remote coaching. The team at IHU Strasbourg did the first sort of like a computer vision guided surgery at the EAES this past summer, using some of their algorithms. And I know Amin is doing some trials in Toronto around using the Go No-Go Zone software that we had developed in the ORs there at UHN. And so I think it's being utilized, and the question is how to do that safely. Part of it goes even just beyond the AI component. I think a lot of that goes into the human factors piece in terms of how do you present this information without creating obstacles in terms of human processing and cognition, and how we take in that data and interpret it to do our surgeries more effectively. From the resolution perspective, I think yes, the resolution is there. I think the compute is the problem. So a lot of these computer vision algorithms will downscale. For example, if you have a 1080p video, most of that analysis is happening on a 256 by 256 image. That just is sort of one of the standard resolutions that we've used. You can do higher resolution, obviously, but then your compute costs go way, way up, especially if you're going to do it in real time. And so that cost component is a piece that needs to get figured out. But I think that's, other than a computational efficiency piece, I think algorithmically that part is definitely doable. And the question is it economically feasible right now? It will be in the future, just given sort of how computational power scales. But the question is how long that'll take.
Thank you.
So I know that a lot of people are running off to the OR, but I think we do have time. Dr. Harvey, is it? It says Harvey's iPad. I don't know who Harvey is. Is it Dr. Harvey? Is it Harvey Sigmund? Is it? You can ask your question, Harvey.
Thank you. It's not Dr. Harvey, it's Harvey Sigmund. So I'd like to really follow up on Dr. Chervenkov's comment or question at the very beginning, because I can see where AI can identify a lot of problems and identify paths to follow. But once we've identified problems, particularly with the teacher as opposed to the learner, how do we change behavior?
I'm not sure the panelists know the answer to that question, but I'd be like, whoever wants to I don't know, provide some sort of thought about that would be very welcome.
I can try to take a stab at it. I think there are two components to it. There's like the human change management component of like, how do you change, behavior? And then there is what can drive that. And I think probably the easiest question or the easiest way to probably address that is, can quantitative feedback to the teaching faculty change the behavior? Say we outline that, this educator is doing really well, this educator, another educator needs to improve. Can really granular feedback help drive faculty development? I think what the outcome of that is always, hard to assess, because humans vary so greatly in our ability to incorporate new data, act on it, and really change behavior. That part, I think, is, probably one of the biggest variables, honestly, that we struggle with in the education of any group. And trying to change behaviors, we're trying to, we're moving towards competency-based education, quantitative data science focus. In that is, what impact is that going to have on our educators and their willingness to adopt these changes that we're putting forth? So kind of a roundabout answer. But hopefully quantitative data will help capture some of that group, to help them evolve.
I agree with Ruchi on that point. I think I could share a little bit of experience. I previously worked on a project during my PhD on a project called the OR Black Box, where we quantitatively measured your performance, like, if there's intraoperative events and things like that, and put it as a report to the surgeons. And, we thought that providing the data itself and pointing out that these were the features, and for the first time really quantifying it, was the intervention on its own. The surgeons could read that, digest that, and then make changes and have the drive to change it. I think a lot of us surgeons have the drive to change because we like to continue to improve, and and we're very proud of that. So I think the drive is there, and finally with the AI tools, we're giving the surgeons sort of the quantified data to kind of make those changes. So really the observation and quantification, are the interventions that the surgeons need.
I think I would also just add, I think going back to the point in that McGill Tribune article about the human machine sort of cooperation. I think, as the panelists mentioned, though we have all of this quantitative data, I think something that one of the actually surgeons at McGill mentioned to me during an interview for one of my studies about EPAs, but she said, these kinds of assessment forms create a platform where I can focus my feedback, and I will know where to focus my feedback on, depending on the score and depending on the level of the trainee. And I think something like with AI and AI enhanced performance assessments, when the assessment is actually, it has quality and that the surgeon kind of accepts that quality and understands that quality, then we can really use those those measures to support us, to support the teaching that the surgeon provides. So I think it's not just a learner thing or a surgeon, like surgical educator thing. It's really I think it's a bilateral situation where AI can really impact both sides, and when it comes together, that's when change really happens.
Yeah, and I think Ruchi put it really well in her intro. Like, we really want to get, and I remember reading this, when I was studying about education, we want to get people, both probably the educator and learner, to kind of work at that optimal, in the education world, it's called the zone of proximal development or whatever you want to call it, but it's that sweet spot where the learning is challenging enough, but not too challenging, so that we can get the most out of each experience. It's already 8:31, so I'm sorry that we have to end. I think we could probably go on for quite a while talking about this really interesting and fascinating topic. So I wish everyone a fantastic day. For those of you in Montreal, please drive carefully in the snowstorm. And thank you again to all the panelists and to the organizers. Bye, everyone.